me for the whole executive board of the IAP AHA 2025. It was a very special year, the Silver Jubilee year of Adolescent Health Academy, and the whole, my team, along with Dr. Geeta Patil and Dr. Sushma Desai, Dr. Arya, Dr. Shamik Ghosh, Dr. Sneha Gatkar, and of course, my all of executive board members from all parts of the 5 zones of our country are very extremely happy that we were together celebrating the Silver Jubilee year for the Adolescent Health Academy. And all this is, we wanted to continue the legacy of all our seniors who have founded the chapter, who have contributed so much to this Adolescent Health Academy that we just tried to take it forward. And we are very proud to say that the super specialty webinars, which was being conducted every month on the first Thursday of every month by the Adolescent Health Academy, was was a result of discussion with Dr. MKC Nair sir. During my tenure, I just asked him what it could be, something different, because we are doing so many webinars on social topics of mental health and metabolic and all the other things which were taken up under the youth wellness activity. And Wave 18 program, we had tried to go to the community through the conducting this initiative, Youth Wellness Initiative. And 18th of every month, declaring this day as the Youth Wellness Day was one of the landmark events of this year, along with UNICEF. This program will continue for the next 4 years. And we have done the immunization module. We have done the parenting, futuristic parenting module. We have done some of the initiatives which are very unique. Having a youth forum itself for AHA was another, involving them in all our activities was one other unique thing which has happened this year. We welcome Dr. Vasant Kalatkar, our president of IAP this year. Thank you, Dr. Vasantji, for joining us in spite of your busy schedule. So we're just starting off, sir, waiting for you. And just wanted to say that all this has happened because of our past chairpersons who had over the last 25 years given us the direction and also the inspiration and motivation to move ahead. And this year, the Yuva or the youth wellness was the main, Empower Yuva was the theme. And we have done all activities around it. And super specialty webinars was purely academic. And because we were, as general pediatricians, we were lost in general topics. And through this purely academic topics, we touched upon to super specialties, because 25 years we wanted to go a step ahead, to go into the deep into rheumatology, subjects like rheumatology, Haemato-Oncology, and cardiology. We had orthopedics, we have dentistry, we had many interesting topics, and cardiology, and some, very people felt it was, they wanted the link and they wanted to go through this webinars again and again, so that we had a very good response. So I really thank Dr. MKC Nair sir for being with us, and we had many interesting sessions. So before we kickstart this last webinar of this year, I want Dr. Vasant Kalatkar to please address us as an inaugural address. Sir, Dr. Vasant Kalatkar, sir, we are very happy. The Adolescent Health Academy is happy to see you again to speak a few words about our AHA chapter. We are celebrating Silver Jubilee year, and this is last super specialty webinar of this year. Over to you, Dr. Vasant Kalatkar.
Yeah, good evening all. Namaste. Dr. MKC Nair, senior or past president, who has done a lot for adolescents. And I think I can't forget him, because I introduced him first in 2006 when he was in Nagpur. Myself and my wife, Dr. Pragati, introduced him. That time he said, Vasant, you have to go ahead. That's all. Still I remember that. Respected Dr. Himavendu, President, Dr. Ramesh, Dr. Arya, Secretary, Dr. Sharma, Dr. Atanu, Dr. Indrashekar Rao, Dr. Geeta Patil, Dr. Sushma, and all. I'm saying Ananda also, then Sivsarani also. So all Rhematology, Oncology. Dr. Singarvilu sir, you all, I welcome you all. Really, this is the great thing, that any chapter is associating with the other chapter, and I think I started this thing which clicked in my mind during the COVID period when I had a neuro webinar. When we had in the topics, all the 14 webinar we had done in on neurology, then I thought, okay, what to do? Then we started association with different chapter, and it was a hit program that time. That neuro webinar with every chapter. It was with rheumatology, hematology also. Every chapter was associated. That was it program. Probably, Imam, you might have taken idea from that, but it's really great and it's needed. But I really want to congratulate that this super specialty webinars you have taken, and that's it today need. Topics may be different, subjects may be different, associate related to adolescence. Really, this is the one chapter that who is really working hard, and I don't know how the adolescent chapter is getting such a one good president, a chairperson every year. सब एक में के ऊपर कष्ट करते आई नो सुषमा इज ऑल्सो रेडी फॉर नेक्स्ट ईयर पूरा करके तैयार है पूरा इधर तो व्हाट इज दिस आई डोंट नो कि एडोलसेंस चैप्टर में जाने के बाद होता है कि दे आर हैविंग देयर इनर वॉइस दैट वी हैव टू वर्क हार्ड रेस्ट ऑफ द चैप्टर दे आर डूइंग बट this chapter is definitely great. I always appreciate the into energy and everything of all. It's not only single president, but all 3,200 hardcore adolescent chapter member really doing the great job. I really appreciate the one thing. Whenever I go to inauguration of the any chapters national conference, this is the only chapter where more than 200 members are there always for inauguration. That's really great. I really I that's why I want to appreciate you people. I want to congratulate you. And today's that topic chosen, that rheumatology and oncology. Really, it's a need that all the pediatricians should know. It's not adolescent people that they will come to know that only about adolescents, but they should know the associated problem with them. So I once again wish you all the best. Congratulations, Hima. I know
Thank
you
you,
have
Vasant bhai.
done
Thank
a
you.
lot for this year, Silver Jubilee year. You said that you will have a 25 program, but I think you have crossed that. Uh, really good. I also was told in at the time of my inauguration that installation that as if this is year is 2025, I will have a 25 program. But I also surpassed that more than 25 program. So I think this is the though it's a year of silver jubilee, but everybody has worked, every chapter has worked. So once again, I congratulate to Dr. Hema, his her team, and all the member of adolescent chapter. Thank you.
Thank you, Dr. Vasant Kalatkar. He was always there for us. Central IP has been very, very supportive to our chapter. And whenever we do any program, they're always for us. Thank you, Dr. Vasantji. Thank you so much. Now I invite our Dr. Neelam Mohan, madam, will be joining shortly. I request Dr. Basvaraja, our past president of Central IP, to speak a few words. Basvaraja ji, we request your blessings for our chapter and your remarks on our super specialty webinar especially. Thank you for your presence.
Thank you very much, Dr. Hima Bindu and our National President, Dr. Vasant Kalatkar ji, and Professor Singarvelu, our incoming President-elect of Indian Academy of Pediatrics, Dr. Atanu Badra, and teachers of teacher who has been a pioneer in the field of adolescent medicine in India, that is Professor M.K.C. Nair sir, Indu Shekhar Rao sir, and all the people who have been very instrumental in taking the adolescent chapter to the greater heights, like Professor Shivanand, Dr. Geeta Patil, many of the stalwarts who has been, and I'm sure the incoming chairperson, Dr. Sushma, Madam, will also take it to the greater heights. So when it comes to the today's webinar, which is a Silver Jubilee webinar, which has been planned with a keeping the adolescent issues which has been going to rise, especially with the recent trend of emergence of immunological disorder, especially rheumatological problem, which has been seen, not that which has not seen in the past. Now, following a post-COVID-19, lot of issues which has been emerging. So this is a specialty which has been very much required, especially with the adolescent issues is concerned, along with hematology also, coming out with a lot of innovative ideas to spread the knowledge of issues which is related to the adolescent in a super specialty way. That's a very creative and innovative idea. I'm sure today's deliberation is also going to make a lot of differences. The best wishes for the today's program. Thank you very much for inviting. Thank you all for it.
Thank you, Basurajaji, for always supporting us. Thank you. Thanks a lot. Now I actually specially welcome our guest of honor, Dr. Singavrelu sir, who's been elected as our national president 2026. A huge congratulations to you, sir, personally from my side, and also on behalf of AHA. We are all proud that we have you as our next president, and we would like to welcome you as a guest of honor for your words for your inaugural address also. Over to you, sir. We all know him. He was the vice president of our Indian Academy of Pediatrics in last year, and then he has gone to become the president of our Indian Academy of Pediatrics for next after Neelam Mohanji, and would like to actually introduce him. He's been a teacher, and we all know that he's a great academician. He's from Tanjavur, and he was the HOD at the Government Medical College, and also been the dean there at Tanjavur Government Medical College. He was the National Vice President, South Zone, as I mentioned, in 2024. And he was also been the Vice President of IMA, TN State, Tamil Nadu, 2022. And President of, course, Tamil Nadu in 2013. He had been the EB member 3 times for a central IP. He has received number of awards. And the Best Teacher Award, I think he was awarded many times by many, the District Collector and Tamil Nadu State, Tanjavur branch of IMA. And that shows that he's been a great teacher. And over to you, sir, with a short introduction for your words for us, for the AHA chapter.
Namaste to all. Thank you so much, Professor Hema Bindu ma'am, a dynamic Silver Jubilee year AHA chairperson who has done extremely well and my good friend for more than 2 decades. At the outset, I thank all the members who assembled here for giving me this opportunity to preside as a president in the year 2027 with all your blessings and blessings of seniors. Definitely we will try to follow what all our seniors has done. And I should be very grateful to our president, Dr. Vasant Kaletkar, and immediate past president, Dr. Basavaraj sir, from whom I did as a vice president South Zone. I learned a lot in IAP, and my mentor and my guru, I can say, for whom I am associated with him, and also through my mentor, our Parsai sir, who always praises about none other than MKC Professor MKC Nair sir, where I have been traveling with him for more than 3 decades, and I can say I'm a true follower. And other past chairperson of this chapter, Madam Geeta Patil ma'am, and chairperson-elect Sushma ma'am, and all the seniors, Sharma sir, Sudesh sir, and so many people, our treasurer Atanu, and Indrasekhar sir, my very good friend, and Ramakrishna Parameshwaran. And if I keep on Anandrao, if I keep on saying, I'll be taking my time. I don't take your time, where today you have a wonderful super specialty where hematology and rheumatology, which is a need of the hour for practicing pediatrician. I enjoyed this year where I attended all the conference of AHA, and it was a wonderful conference which was in Ahmedabad and also at Hyderabad, which was very useful to all the practitioners, and AHA is doing extremely well because Geeta Patil ma'am and others which formed a way, and definitely Hema ma'am excelled this year, and he brought a lot of innovative ideas. Definitely it is going to help our adolescent children and also the practitioners how to take up the adolescent issue. And this super webinar definitely specialty webinar will go very well. And I do not take in the in between the academics. Once again, my big thanks, and I need all your blessings and encouragement. What best I can do, what MKC Sinayar and our Bazora sir and others, our Vasant and what all they done. Definitely, we will try to follow and make our academy a better one among the public and also to our members. Thank you once again. My sincere thanks to Hima Bindu ma'am for inviting me and giving this great honor. Thank you all. Wish you all the best.
Thank you, sir. Thank you. It's our privilege and honor to have you. Actually, I'm sorry for the other academicians are waiting because this is the last super specialty webinar. We just wanted to thank our central IP and all our leaders for supporting us. Today, we have a lecture by Dr. Sirisha Rani and also a panel discussion which will be moderated by Dr. Anand Rao. We have Dr. Anju Singh, Dr. Anu Maheshwari, Dr. Gurpreet Singh, who will be, and Dr. Suma Balan, who will be with us today. And I also welcome Dr. Indrashekhar Rao, Dr. Chawla sir, Dr. Ramkrishna sir, Dr. Sudhir Chaudhary sir, many others. But I would like to invite Dr. MKC Nair sir for his remarks on the super specialty webinars. We had 12 such webinars, sir. Successfully, we have done throughout, I think, except in the month of August, when even in that month we had done all the 12 webinars except October. So that is 11 webinars we could do, sir, on different topics in adolescent health. So your remarks on this and your suggestions how to go about, and we thank you for guiding us, sir. Over to you.
Good evening, IAP presidents, present, past, and future, the next incoming president of AHA, everybody, because I want to save time, only 3 points. Number one would be that I must congratulate Himabindu for doing such a beautiful program throughout the year. I think I have not missed even one, everyone. Today I am into something else. So I said I will give you 10 minutes only. I have to leave, but still now it is 20 minutes, no problem. So that's the first point I have said. I must congratulate her for her determination to do something, and that is a great quality. Number two, from 3 stages, adolescent chapter has gone. I remember the first meeting with 11 members. Now we are in thousands. Okay. So first time we were talking about family life education at a teen club. Then second phase, we started doing teen adolescent clinics. This is a third stage where we are talking about specialty. That means we are matured. Now we are actually young adult, matured young adult, going into adult. So that is a great thing. And number 3 would be I never seen so much of affection of all the IAP leadership for just like what we get for adolescent chapter. It is amazing how you are able to manage bring all of them, because all of them are so busy with so many things, which only shows that. And there was a question I think President asked, why so much of number of people coming for adolescents? So only one reason, not 2 reasons. Only one reason. All of us are suffering with adolescent children, our own adolescent children. So we want to learn something new from this one. Thank you all. And sorry, I have to leave because I have another program.
No issue, sir. Your presence itself, gives us a lot of motivation and inspiration to carry on. Thank you for your blessings, sir. Especially from my side, you have always been very, very supportive and directed and guided us in many ways. And as a mentor, my mentor, I would like to place my gratitude to you, sir. Thank you so much.
Thank you all. Thank you all very much.
Thank you. Now I request Dr. Geeta Patil, short message, then we can start with our lecture. Dr. Indrashekhar Rao also is there. Yeah.
Yes, thank you, Dr. Himabindu. I think I should not take everyone's name, but IIP President Kalatkar sir has supported us. Neelam Mohan Madam is going to support. Baswara sir has also supported us. Atanu Bhadra is there. And we know that MKC sir told, without IIP being standing behind us, we cannot be very much go ahead in all the activities. And really, you have done a great work in all the aspects of the adolescent health. And this is a really a great height that we have reached up to the super specialty webinars. And this is the 11th webinar very successfully. We know that chronic diseases, because of the medical advances, we need to know about these things. And you have done a great job. And today's is, you don't say this will be the last. Definitely Sushma Desai madam will take it forward for the next year, whatever left out topics apart from these 11 topics, because there are many chronic problems are there.
Yes.
So thank you very much.
Thank you, Geetaji.
And
Dr.
congratulations, Dr. Singarvelu, sir.
Yeah.
I think you have got many things to do, sir. And I know
We'll
that you
not
will
leave
definitely do.
Singarelu, sir. Yeah.
But,
Dr. Atanu Bhadra, Treasurer of Central IAP, I request your address. Dr. Geetaji, just can you call him, because I saw him, he's
yes,
joined,
yes,
and yeah.
yes, 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 I'll do
Dr.
it.
Indrishakura, sir, just one line message if you would like to, because you're one of the senior most members, then we can. Dr. Indrishakura, sir. Okay, I think while we have Dr. Atanu Bhadra coming in, I would like to introduce our speaker. So we have a lecture on the Haemato-Oncology aspects, and Rheumatology. We have a panel discussion. So the speaker is Dr. Sirisha Rani. Dr. Sirisha, thank you for accepting to be with us today. And she has done her MD Pediatrics and Fellowship in Pediatric Hematology and Oncology and Bone Marrow Transplant from UK. She is a senior consultant in pediatric hematology, oncology, and bone marrow transplantation. She is working at Rainbow Children's Hospital at Hyderabad, and her areas of interest are acute leukemias and stem cell transplantation. She's been an EB member of the PHO and CCLG and CICIP member and also, of course, IAP member. She has been a postgraduate from PGI Chandigarh, awarded as the best outgoing student the fellowship in pediatric hematology oncology and BMT in UK from prestigious institutions like Wash, Bristol Children's Hospital, University College of London Hospital. And she's well known in Hyderabad and of course in her own chapter. And she's very accessible, very knowledgeable, very practical. I would like to say that I think we would like to work with her more in the HA also. We thank you, Dr. Sirisha, for accepting to be with us today and to speak about common hematological and oncological disorders in adolescents and young adults. Over to you, Dr. Sirisha.
Thank you very much, ma'am, for your kind introduction, and thank you very much for this wonderful opportunity. I have just learned that I'm the last batsman of this specialty webinars of this year. I hope we are going to have a good session. Coming to adolescent hematology and oncology, why we need to discuss that, we will just go through a few slides, like, why we need to discuss that separately from pediatrics and adults, adolescents and young adults, how they are different, and various hematological and oncological issues. We will see what is the global burden and what is the local burden, and what are the various presentations through few case scenarios we'll see, and how do we manage them, and what are the challenges in that. So these are the aspects what we are going to touch base upon. So first and foremost thing, as we all know, anemia is one of the most important problem. Iron deficiency anemia in that is very important issue what we handle in adolescent age group and young adults. This most of the times it is secondary to nutritional factors, because we know that in the adolescent age group they develop a different perspective towards diet, and at the same time they also go through the problems like celiac disease and all during this age group other than childhood, and at the same time they also go through the problems like Crohn's disease, inflammatory bowel disease, where they will have absorption defects. And of course the most important thing, iron deficiency anemia cause in females is like blood loss. As we all know, like, in the initial period they will go through irregular cycles, and there may be menorrhagia. So during that time they are prone for significant anemias, and some of them they do require transfusion, some of them they do require just iron infusion, and they do require looking into causes leading to heavy bleeding. And other than that, megaloblastic anemia is one of the important thing, because they move to hostels during this phase of life, as adolescents and young adults, and at the same time they also develop, as we just thought, like they develop different perspective for diet, and then they go off non-vegetarian diet or iron-rich diet, where they are prone for megaloblastic anemia also at the same time. And of course, absorption defects like pernicious anemia and all are also, like, during this period we do see. And other anemias like hemoglobinopathies during this period. Sickle cell anemia may present at this age group. Non-transfusion dependent anemias also we do see. And adolescent care of transfusion dependent thalassemia syndromes is another important aspect what we all need to be aware of. And as we know, spherocytosis is another thing what we diagnose frequently during this period. And in addition to that, other hematological disorders what we face in this age group is, of course, ITP and von Willebrand disease, especially type 1 in girls, where they present with menorrhagia, hemophilias in boys, where they come with the problems with poor joint health, because they would have already had recurrent bleeds into the joints, or they may come with inhibitors and significant bleeds. And other than that, rare bleeding disorders where like Bernard-Soulier syndrome and all, they can present with menorrhagia in girls. So we will also see that in the case scenario. And bone marrow suppression problems, whether it is post-infection or idiopathic or inherited. So these problems also we do face. And if you look at anemia incidence, of course, we all know that it is very much prevalent in Western world. It is to the tune of 25 per percent in men, in adolescent and young adults, and definitely that is higher in case of developing countries. And the same thing even for women also, it is higher in developing countries. And of course, it is more than half of the pregnant women are also age group are anemic. Globally, as we all know, like this age group is very important in terms of learning, puberty, growth spurt, and at the same time, uh, they are also prone for various. Sorry, someone is uh, scratching on the IS. One of the iPhone users are doing the lines, I guess. Can you please stop that? So during this adolescent period, as we all know, it is very fruitful period where they will have maximum learning capacity and maximum working capability and formative phase of the life. Hence, it is very important for them not to get into significant anemias, and it is very important to recognize anemia in this phase. And as we just saw, like, iron deficiency is one of the important thing other than that B12, and folic acid deficiency also can lead and absorption defects, as we just saw, like chronic disorders like renal disorders or inflammatory bowel disorders or Crohn's disease and all can cause absorption defects in iron and B12 and can lead to anemias. So hemolytic anemias, let's go through, like, what we need to monitor in adolescent period. If they are transfusion dependent anemias, thalassemia syndromes, or other enzyme defects like congenital pyruvate kinase deficiency, these kind of people, they are dependent on transfusion. Some of the variants, like, they are dependent on transfusion. So what do we monitor them? One is most important thing is chelation. So we have to ensure that they are adequately chelated so that they are not going to go into iron overload of the body, leading to endocrine dysfunction, heart, liver problems, and overall issues in terms of pulmonary hypertension. And also, we need to go ahead and monitor the iron overload in terms of monitoring the ferritin, doing T2-star MRIs, controlling with the chelation, at the same time doing viral serology check and endocrine check at the same time. They have to be in regular follow-up with them. And of course, they are prone for psychological issues. We all know that when they are going away from the college or workplace, so for regular transfusions, definitely takes their self esteem down, and then their morale down, and they are prone for, there are documented published studies which says that they are prone for psychological issues in this, especially in adults and as the adolescent and young adults. Hence, we need to go ahead and address that issue also. As we know, in India, that is not very much taken care, but we need to be aware of that. And of course, fertility issues and pregnancy, we have to address those. So we need to ensure that they are going through puberty, and then fertility issues should not come when they get into marital life and all. During pregnancy, we have to take care that, we need to counsel them that without informing, they should not get pregnant, because they may be on hydroxyurea, they may be on chelation, that can cause problems with the teratogenicity. Hence, we need to warn them in advance, and they may face issues with jobs, insurance. We all know that. So we need to educate them in terms of, like, how to handle those issues. And at the same time, we also have to monitor them for hepatocellular carcinoma. So especially if viral serology is positive, though it becomes negative with the treatment, still we need to monitor alpha fetoprotein so that they don't get into sudden surge of like HCC coming up with raise in alpha fetoprotein. So those things are very much important when they are on regular transfusion. When they are on not regular transfusion also, still it is a big issue. So we need to be very careful in terms of end organ function, because when they are not on regular transfusion, they are prone for iron overload, as constant anemia also triggers iron absorption from the gut. So we need to go ahead and monitor iron or ferritin levels in these cases, and then we have to go ahead and address the iron overload in them. They are prone for pseudotumors, spinal compression, presenting with spinal compression secondary to pseudotumors because of the hematopoiesis is also very well described, and they are prone for chronic non-healing ulcers at the same time. So we need to be very careful in non-transfusion dependent hemolytic anemias. So coming to, we have seen anemias. Now moving on to pancytopenia. So there are various reasons for pancytopenia in adolescents and young adults. Nutritional factors, one of the common thing, megaloblastic anemia. So we'll just see the scenarios as well. And at the same time, hemolytic anemia presenting with massive spleen also can cause hypersplenism and pancytopenia. Autoimmune causes like SLE also can lead to cytopenias. SLE without HLH, secondary HLH, causes mild cytopenias. SLE with autoimmune hemolytic anemia or Evans syndrome causes significant bicytopenia. SLE with HLH causes significant pancytopenia. So SLE can behave in all the three different forms in adolescents. So whenever we see cytopenias, we have to be very careful in monitoring for this condition. So at the same time, viral infections, acute infections, whenever they get infection on with underlying deficiencies, it may be iron deficiency, it may be B12 deficiency, cytopenias can get aggravated. And at the same time, malignancies, acute leukemias present with pancytopenia, subleukemic presentation, what we call it as. Around 5% of leukemias can present with subleukemic presentation, that is very well described in young adults and adolescents. And inherited bone marrow failure syndromes, PNH, TTP, these are also like, important things what we need to be aware of. So just to highlight one short case, this is 14 years old girl who presented with progressive weakness, fatigue of 1 month duration, had significant pallor, icterus. So whenever we see pallor, icterus, we tend to think of hemolytic anemia. Yes, there is a hemolysis happening, but not because of, if you notice, MCV is high, bilirubin is high, indirect especially, with some cytopenias, platelets are significantly low, WBC is also low. So, and with high LDH, you also tend to think like with high LDH, is it a malignancy? However, with the smear examination, with macrocytosis, with MCV being high, with indirect hyperbilirubinemia, with without any atypical cells in the peripheral smear. So more or less you should suspect, especially in adolescent age group, you should suspect that you are dealing with the B12 deficiency, and we should go for the B12 levels assay, which for this particular case I had very low B12 levels. So it's a megaloblastic anemia. Megaloblastic anemia can present with a hemolytic kind of picture because they were prone for intramedullary hemolysis of the RBCs, which gives rise to high LDH, indirect hyperbilirubinemia, ictras and all when you examine them. So that is one of the thing what we need to be aware of. And at the same time, when you have high MCV with hemolysis, you also have to rule out endocrine causes like hypothyroidism and all. So, coming to another case scenario, this is the adolescent girl, early adolescent girl, I should say, who has presented with a significant bicytopenia. So HB is low, platelets are significantly low. WBC neutrophils are not very low. There is some leukopenia along with neutrophils being on the lower side for the age. Smear showed here, so peripheral smear examination is very important for hematology. So we always have to remember that we need to discuss smear with our pathologists. So had crenulated RBCs, schistocytes, low platelets and all. So whenever you see crenulated RBCs, schistocytes and all, definitely you think of HUS. However, here you also have to notice that she had altered sensorium and seizures. So whenever we have predominant CNS symptoms compared to predominant renal involvement, you always have to think like, can it be problem with the TTP rather than HUS. So ADAM-TS 13 levels were very low for her. Less than 10 is clinically very significant. So she had very low ADAM-TS 13 levels. So she is the case of TTP. And going by age, going by her behavior, and even we did genetics also for her. So all the parameters were suggestive of acquired TTP rather than inherited condition. Coming to another case, 15 years girl. This is a sudden onset anemia of few days duration following viral illness, no organomegaly, high MCV with significantly low significantly low hemoglobin but mildly low platelets. So this, whenever we see this kind of picture in adolescent, of course we always go for ANA. So ANA was low positive 1+, but profile is normal. She was treated with steroids as autoimmune hemolytic anemia because her DCT was strongly positive. So she was treated with steroids. She was well for 1.5 years. Later, she had recurrence. When she had recurrence of autoimmune hemolytic anemia, when ANA was repeated, that time it became positive. So strongly positive, DSDNA positive. So one time negative will not rule out the problem. So if you have recurrence of cytopenias, you always have to go ahead and suspect that this could be, SLE, especially in girl adolescent age group. You need to be careful. And bleeding disorders in adolescents. So we saw like various types of anemia, pancytopenias. So now coming to bleeding disorders in adolescents, they are very much prone for ITP. So ITP, it can be acute, it can be chronic, it may be remitting relapsing course, may not be chronic, just remitting relapsing. We need to be very careful in adolescent girls who have attained menarche because they go through recurrent menorrhagias, severe pallor, and come with the significant pallor requiring transfusions. And also in those cases, treating ITP even for moderate cytopenias will become significant because generally ITP, we know that when they are bleeding, only we treat, or you don't get significant bleeds even when you drop up to 20 to 30,000. So that is the dictum what we usually follow for young kids, but that is not true for adolescent girls who have who attain menarche. So where you have to keep your threshold of platelets little on higher side. So the next problem is hemophilias, where, as I mentioned, hemophilias in adolescents may come with, because of recurrent bleeds, they may come with poor joint health, or because of recurrent exposure, they may come with inhibitors. But nowadays, hemophilia picture has changed. So majority are going on to emicizumab. We have wonderful support by our government, and then emicizumab is coming free for our kids, hemophilia children. So hopefully in the future, joint health in adolescents as well as in vitro incidents, what we have seen in the past, should not be a problem. However, they are the problems what we may face in adolescent age group in hemophilias. And at the same time, von Willebrand disease, especially type 1, type 3, do present in the adolescent period with the menorrhagias. And rare bleeding disorders, I'm just going to give you one scenario. So this is adolescent girl. This family, two kids, two girls. They both have Bernard-Solier syndrome. They both have moderate thrombocytopenia. Both repeatedly come to us with the menorrhagia, severe pallor. So Bernard-Solier syndrome, out of both the Glanzmann's and platelet function disorder, you think mainly Glanzmann, Bernard-Solier. In that, Bernard-Solier is a milder form. So generally in boys, Bernard-Solier goes unnoticed at times because they don't get into significant bleeds. But in girls during menarche, after attaining menarche, say they go through recurrent menorrhagia. So that is one thing what we have to remember. Here we always go for simple tranexamic acid, platelet transfusion, but majority of the times those two will not help and they end up going on to hormonal treatment. So as young adult, you can go for even coil and all, but as a young, early adolescent period, doing those invasive procedures is very difficult. Hence, they have to go through the platelet transfusion, hormonal therapy rather than going for uh, long-term things. So coming to next topic in hematological problems in adolescence, that is inherited marrow failure syndrome. Fanconi anemia, average age of presentation is 8 years. Dyskeratosis congenita, average age of presentation is 10 years. So usually Fanconi anemias, they do get diagnosed before adolescent, but dyskeratosis congenita, you have various forms where you do see adolescents coming with cytopenias. Discoloration starts at around 10 years of age. Cytopenia starts around 13, 14 years of age. So they may present even in young adulthood also, or they may present in late adulthood also with various skin manifestations, as you can see, like dyskeratosis, nail dystrophy, mucosal leukoplegia, and all are well described in this condition. So out of inherited marrow failure syndrome, this condition, particular condition, will present in adolescents and young adults. Otherwise, most of the other inherited marrow failure syndromes presents in a young age itself. So far we have seen like cytopenias, bleeding disorders, anemias, and all in adolescents and young adults. So how about oncological problems? In oncological problems, when, as we all know, oncology problems repeatedly, they have to come to hospital visits for chemotherapy, whether you take it as leukemia or other solid tumors. So first of all, we have to realize that they don't like to come to um, uh, a bed which is next to young kid. So as sir one just was mentioning, like adolescents, they will have their inner voice that they don't express, but we need to understand that they do need dedicated adolescent wards. So in UK, we always used to have like separate adolescent unit. In India, the concept is evolving, so we are trying to segregate the adolescents, but it is not strictly happening. We need to go ahead and do that. So that is one thing I want to say. And on the other hand, coming to common problems, common oncological issues. So just like adults and young kids, adolescent cancer incidence is also increasing globally. This is mainly because of, not only because of the number of cases are increasing, also because of the better awareness where to go, how to get diagnosed, and when to get treated. And also this awareness has increased the incidence of cancer. At the same time, number of cases are also increasing. So if you look at outcomes of adolescents compared to young kids, definitely worse. Compared to adults, so definitely better. So they come in between young kids and adults. So that is one thing we need to go ahead and remember. So coming to different types of cancers, what we see, we do the incidence of, even in adolescents and young adults, ALL is more common compared to AML, but the incidence of AML goes up after 10 years compared to young children. So that is the reason why when you see AML, you see more in the higher age group. That is one important difference. However, at the same time, brain tumors like pilocytic astrocytomas, other gliomas, especially in lymphomas, Hodgkin's lymphoma is the disease of adolescents and young adults. Non-Hodgkin's lymphoma is also known in these children. Sarcomas like osteosarcomas are more common in adolescents and young adults other than HCC. The incidence of HCC is like after 12 years. It's very extremely rare to see HCC below 12 years. So HCC is more common after that age group. HCC, you generally what we see like, for kids who was chronically transfused in the past with seropositivity, you do see more rather than going ahead with the direct incidence. So the burden of cancer in this age group is definitely a significant problem which requires specific attention, because here when you are giving chemotherapy, not only the cure, also the quality of life at that point of time as well as future. So especially fertility issues with fertility, marriage, and responsibilities at home. In young adults, they will have responsibilities at home in terms of job and other responsibilities. So uh, you have to address school absenteeism, college absenteeism, work absenteeism, and home conditions. So all these things we have to include in the counseling, other than chemotherapy, what we are giving, and then supportive care, what we are giving. So this is the various types of cancers. This is busy slide. I'm not going into details. So as I just mentioned, adolescent cancers definitely have better survival compared to adults. However, the survival chances are less compared to young kids. So how to treat them? Who has to treat adolescents and young adults is adolescents definitely by pediatric. Young adults comes into gray zone. So either by pediatric and adolescent oncologists or adult oncologists. So both the ways we can go ahead and treat. However, protocols which are more aggressive for pediatrics have better outcomes compared to protocols which are gentle for adults, because of comorbidities, associated comorbidities in adults. So definitely the protocols are different in adults compared to pediatric protocols that are designed for the oncological issues. So other than sarcomas, leukemia differences and all, the other cancers that have increased in incidence compared to children are colorectal cancer. So one of the important aspect is the diet. So of course, for colorectal cancer, healthy diet habits are very important. And at the same time, we also have to be aware that thyroid carcinoma and cervical cancer incidence also goes up as they move to young adults. So what the difference we have just seen, like, how it affects the fertility and how we need to address the preservation of gonads as the ovum and the sperm, and also needs to be discussed at the same time when we are offering the chemotherapy. Other than chemotherapy, their long-term outcomes, and at the same time, you also have to address the socio-economic problems, and at the same time psychological issues. So because they are very much prone for psychological issues in this age group, so we need to go ahead and address that. So, and other than that, like vaccination is very important. So screening techniques, we always, many parents, they ask us like, what are the screening techniques in children? So in children compared to adults and young adults and adolescents, so you don't have screening techniques because cancers in children are rapidly evolving compared to adults, where the evolution is slow. So you do have time for screening, especially breast and cervical cancer screening. So here the vaccination definitely come into picture, because if you have, if you take the example of cervical cancer, it's a huge success story where vaccination is slowly bringing the incidence of cervical cancer in women, and then reducing the mortality morbidity related to that. So hence we have to actively advise them to go for the vaccines like HPV vaccine, both in girls, and of course it is equally important even in boys to control the incidence of penile cancer. So it is recommended even for boys. And at the same time, the IAP currently, I'm sure, like, you are more well versed in this schedule than us. So now IAP also recommends, like, they need to, because of the slow waning of your effect of vaccines that have been given in early childhood, it is always recommended to give catch-up vaccines during this time. This will help in decreasing the incidence of cancers, one, and at the same time, even when you get into problems, any chronic disease or cancers or whatever it is, you do have certain immunity, at least related to these communicable diseases. Hence, the tolerance of treatment is definitely going to be better. So hence they do recommend that we have to go ahead and give, not only for general well-being, also to address the chronic diseases. So hence vaccination schedule is recommended in this format for adolescents and young adults. So as we have just seen, like adolescents and young adult disorders related to hematology and oncology are different, and they do need separate care, and they do need proper transition care when they are going from pediatric to adults. So in terms of treatment, in terms of awareness about the different problems, and in terms of transition care, we must be aware of these various aspects. Thank you.
Thank you, Dr. Sirisha. That was a very good, concise presentation about adolescent hemato-oncology. There is so much to talk about it individually, but I think, at least we are all aware now what to do when we see children, adolescents with cancers and carcinomas. Thank you so much. Any questions from the audience? Maybe the questions can be put in the chat box and Dr. Sirisha can answer them. So we thank you, Dr. Sirisha, and we'll be in touch with you for the future. Any issues, any programs, any cases, please be with us for any clarification. Thank you. Now we'll soon go on to our panel discussion. The panelists are waiting, and I would like to introduce Dr. Anand Rao. Anand Rao, sir, are we all ready for the panel discussion? Yeah, Anand Rao, sir, is ready. So he's a consultant pediatric rheumatologist. Coming to rheumatology now. So we have a very good panel led by Dr. Anand Rao, who's been working with Manipal Hospital and Indira Gandhi Institute of Child Health at Bangalore. And he has been an MBBS, is graduated from Bangalore Medical College. Later, he has done his MD from Grand Medical College, Mumbai, and has continued to do a fellowship in pediatric rheumatology from Gaslini Hospital, Genoa, Italy. So having got the degree from Italy, he has been practicing here in India and Bangalore, and he's been attached to the Indira Gandhi Institute of Child Health as a consultant pediatric rheumatologist, and also been practicing at Manipal Hospitals, Bangalore since 2010. And I would like to also tell a few words that he had started the first pediatric rheumatology clinics in the state of Karnataka, both in the corporate hospital and government hospital, started the first pediatric rheumatology fellowship program in South India. And he had 27 publications to his credit. And over to you, Anand Rao, to please introduce your panel and start discussion on the common issues on pediatric rheumatology in adolescents. Over to you.
Thank you so much, Professor Haemabindu. Is my screen visible?
Yes, yes.
Okay. We have a very eminent panel today, which includes Professor Suma Balan from Amrita Institute of Medical Sciences, Kochi. She is the professor and HOD of the Department of Immunology and Rheumatology in Kochi. We have Dr. Anu Maheshwari, who's from Delhi. She's a professor of pediatrics in Kalavati Saran Hospital and Lady Hardinge Medical College. And we have Dr. Anju Singh, who's a pediatric rheumatologist at Artemis Hospital and Rainbow Hospital in Delhi. So welcome, I welcome all the panelists. And we have about 8 cases. Dr. Himabindu, how much time do we have? Because I think we are already
Yeah, we are a little bit short of time. But then we also have to hear from Dr. Gurdeep Singh. He is
Okay,
bringing a youth voice. He's
okay,
a pediatric rheumatologist from Ludhiana, assistant professor. So we
okay.
want to know how the young people are suffering from this rheumatological and hematological issues. What is their experience? The youth voice, we need to give some time for him. So it's
Okay.
okay. Please take your 30 minutes. Can we do in 30 minutes?
You can cut me when you think you had
Yeah,
enough.
yeah, sure, sure. Please carry
So
on.
I will stop at that point of time. We have 8 interesting cases. Let's
Mhm.
see if we can finish that in 30 minutes. Okay, so this is what caught my eye when I was researching. Who's a pediatric rheumatologist is a person who solves problems you don't know you have in ways you can't understand. Something which was even more unique was a person who does precision guesswork based on unreliable data provided by those of questionable knowledge. Now, let us see with these things which have been put up about us, whether we can solve a little bit of a complicated issues which we have had 8 patients to deal with. So now let us start with case one. A 13-year-old girl presented with fever of 3 weeks, skin rashes over lower limbs since the past 2 weeks. Since she comes from a very rickettsial endemic area, she was treated with by a local pediatrician as rickettsial fever with doxycycline. What happened is 3 months down the line, she continued to be sick. She was treated with multiple courses of antibiotics. She presented with bloodstained sputum and breathlessness, and she also had decreased urine output for a last couple of days prior to admission. So she was treated as a severe bacterial pneumonia with a multi-organ dysfunction, but there was lack of response, and that's why that prompted a referral. So the story spans over 3 months, and this transpired about nearly 12 years ago. So when you examine the child, she was febrile, tachycardic, tachypneic. She had hypertension. She had purpuric and petechial spots over the lower limbs. She had bilateral crepitation, and she had hepatosplenomegaly. Dr. Anu, what do you think is happening here?
Good evening, sir. This is a very interesting case. First of all, the first diagnosis of fever with rash, they treated with doxycycline in a rickettsial endemic area seems perfectly okay. But infections should not be thought of if the disease has spanned over 3 months. You need to think of something beyond infections here. This child has fever, has multi-system involvement of the skin, your kidneys because there's hypertension, and then there is a crepitations, probably something happening in the lungs, and also some systemic manifestations because of hepatosplenomegaly. So we have a systemic protein systemic inflammatory disorder, probably maybe lupus or vasculitis or something autoimmune going on. We'd like to see what the investigations hold for us.
Absolutely. Thank you so much, Dr. Anu. So, Dr. Anju, Dr. Anu asked for investigations. Now we have these investigations. What do you make out of it?
Good evening, everyone. If we look in the investigations which have been enlisted over here, they are abnormal hematological parameters, and also there is component of nephritis along with elevated acute phase reactant in the form of high ESR. But I think CRP is normal, less than 6 is normal.
Absolutely.
So CRP is normal, high is pancytopenia like picture with there is lymphopenia in the blood parameter, along with a nephritis presentation in the form of raised serum creatinine and abnormal urinary findings there. So they are urinary sediments, 3 plus proteinuria. So it is showing abnormality in the blood picture as well as impaired kidney involvement is there.
Now I show you this X-ray and the CT scan of the thorax.
So in the X-ray, we can see diffuse infiltrates are there in both the lung fields, and which is corroborating with the CT finding of diffuse opacities in both the lung fields. So most probably the child is, this girl is having one can say ARDS like picture, or other possibility could be, if we are thinking about autoimmune disease, could be a entity called diffuse alveolar hemorrhage.
Absolutely. Wonderful. So, what do we have here? So, we have a prolonged febrile illness with the vasculitic rashes, severe anemia, thrombocytopenia, and there is renal and lung involvement, which seems to be something which is called as a pulmonary renal syndrome. Now, when we investigated further, we had ANA, which is high titer, anti-DSDNA titers being positive, complements being low, and a renal biopsy which was done showed a very active class 4 lupus nephritis. So this was a lupus with pulmonary renal syndrome. The child was admitted to the ICU, ventilated, was given immunosuppression in the form of cyclophosphamide IV steroids, and was started on daily plasmapheresis for 5 cycles. Thankfully, the child made a miraculous recovery and has done well subsequently. Dr. Suma, you have had a lot of experience dealing with lupus in your career, and I think Kochi is a hotbed of lupus. So, when would you suspect systemic lupus in a ICU or a ER setting?
Thanks. Good evening, everyone. So basically, when you have a child presenting with any prolonged fever, a presence of a secondary HLH, particularly in an adolescent female. However, do not think that boys do not get lupus either. When you have pancytopenia, a secondary HLH, as an autoimmune hemolytic anemia, any presence of catastrophic antiphospholipid syndrome, so multiple thrombosis that can be presentation of saying press. When you have an adolescent with press, renal failure, when you have an adolescent with TTP. So I think Shirisha showed us a couple of cases earlier as well in her collection. So these are all scenarios when you have a child also with acute neurological presentations in the background of lupus. So you can have infarcts, you can have an encephalopathic presentation, you can have a number of neuropsychiatric presentations which can all present acutely in the ICU and the ER. And severe ITP can be also a presentation. You should look at the other clues like you saw in this child, lower counts, high ESR, normal CRP. These are all not what you would see with just an ITP. Yes.
Thank you, Suma. And should a pediatric rheumatologist be involved in care of these patients?
Definitely. Every child with lupus should be under a pediatric rheumatologist. This is a chronic disease. They have it with them for life. They need appropriate treatment because in the long term, it's not only the disease that causes damage, the drugs can also cause damage, and you need appropriate targeted therapy at all stages of the illness.
Thank you so much, Suma. So we'll go to the second case. A 15-year-old girl who came with complaints of febrile illness of 2 months duration associated with epistaxis requiring blood transfusions. So keep that in mind. She had history of hair loss and oral ulcers, was noted to have thrombocytopenia. So, Dr. Anu, what are your thoughts when you have a scenario like this?
Unmute करिए please.
Yeah, taking a clue from the last case, sir. Again, this is a girl who presented with febrile illness of 2 months. So here the infection, the possibility of an infection really comes down. The natural history of infections should go away except for tuberculosis in 6 weeks or so. So this child has epistaxis, so that means there's something wrong with her clotting or platelets, and history of hair loss, oral ulcers, again mucocutaneous findings, and thrombocytopenia. So multi-system disorder, again, I would think in lines of lupus only, sir, in this case.
Absolutely. Wonderful. So, subsequently, she was evaluated by a very wise pediatrician. She was found to have ANA being very high titer positivity with DSDNA titers and low complements. She was noted to have lupus anticoagulant positivity with anticardiolipin IgM antibodies. So when you have these antibodies, these predispose one to thrombosis. So though they are antiphospholipid antibody, anticoagulant pository, they tend to predispose them to thrombosis. So she was diagnosed as lupus with secondary antiphospholipid antibody syndrome and started on IV methylprednisolone followed by oral steroids and hydroxychloroquine, and aspirin was used as a primary prophylaxis against the thrombotic events which are associated with antiphospholipid antibodies. So what transpired subsequently was she was not compliant with treatment. 3 4 months, couple of months later, she came back with weakness of right side of her body. And when she was evaluated, she was found to have right-sided hemiparesis. She was noted to have vasculitic rashes over palms and soles, which indicates that there was active lupus which was ongoing. What happened? What transpired, Dr. Anju?
This child who has been diagnosed with SLE along with secondary antiphospholipid syndrome, and who was put on treatment, but somehow she was not adherent to the treatment. So most likely the child landed up into the further progression of the underlying disease of SLE, or it could be because of antiphospholipid syndrome as well. So she presented with hemiparesis, which could be because of the neurological involvement, either in the form of vasculitis of SLE, or it could be secondary to the thrombosis due to antiphospholipid syndrome,
Thank you so much.
antiphospholipid antibodies.
Thank you. Thank you so much. So when we evaluated, once again, similar picture to the first child, anemia, leukopenia with borderline thrombocytopenia. Once again, you notice that there is elevated ESR on low CRP and APTT is prolonged. And MRI reveals infarct in the left internal capsule. She was started on treatment with low molecular weight heparin with aspirin and IV steroids. In the wards, when she was being treated, she developed sudden onset breathlessness. She had significant orthopnea and she had to be evaluated. So, Suma, what do you think happened suddenly?
So clearly,
What?
she's gone into cardiac failure. And we have to look at, so one of the uh, associations with antiphospholipid antibodies is Libben-Sachs endocarditis, where they can have massive vegetations. These are sterile vegetations, particularly on the mitral and aortic valves, and they can develop a sudden acute regurgitation, which can lead to cardiac failure, which can be a very serious complication and quite difficult to treat as well.
Thank you so much, Suma. You have been very good with this. Now, you have seen many APS manifestations. Can you mention about a few which have caught your eye or you can remember very easily?
So thrombosis is something. You can actually even get coronary artery thrombosis with APS. I remember a patient who had lupus nephritis with renal vein thrombosis, such that the child had severe lower limb edema, looking almost like elephantiasis. And you could not do there was evidence for the lupus nephritis. We could not biopsy this patient because of the large renal vein thrombosis. Then we've seen a number of neurological manifestations, so chorea. And in fact, patients have been, because they have presence of chorea, presence of vegetations in the cardiac valves, they've been presumed to have rheumatic fever and kept on penicillin prophylaxis, when the actual cause was actually lupus with a similar presentation. The clue would have been in looking at the counts when the child first presented. So low counts, high ESR are against rheumatic fever at any point in its presentation. And the problem with these kind of things is that this is not enough adequate treatment for the patient. And if you don't treat the active lupus and the APS, then the neurological insult they get does not get better as well. I've also seen a child with a bleed, a frontal bleed, secondary to APS and a neurolupus. And this child subsequently developed epileptic encephalopathy and has developed a cognitive deficit because the initial manifestations were missed. So there can be a very wide range of presentations that you can get. You can get deep vein thrombosis, you can get cerebral venous sinus thrombosis, and you can get central retinal artery, central retinal vein occlusion. So there can be so many other manifestations of APS that can be you can get Budd-Chiari due to portal vein thrombosis.
Suma, you have talked about thrombosis. Any APS manifestation where there can be bleeding because it's contrarian to
Thrombocytopenia. Thrombocytopenia.
apart from thrombocytopenia.
So you can get also what we call the hypoprothrombemia,
acquired hypoprothrombinemia.
Thrombonemia syndrome, which with APS antibodies positive, and these patients can
Absolutely.
These
So
are the
this
ones who
case
approach the
was
bleeding.
absolutely. So
LAPHS, lupus anticoagulant
associated
hypoproteinemia.
hypoprothrombinemia syndrome. So you can have this case was to illustrate that antiphospholipid antibodies can be primary, but they can be secondary in a setting of a rheumatological disease, and they need to be managed very well so that these patients don't end up with a stroke or any other complications, and they need to be managed well. So 2D echo was done as Dr. Suma had suggested, which revealed severe mitral regurgitation with a poor LV function, and the child succumbed to the same. So case 3, 16-year-old adolescent female started, the story is once again 14-year-old, so started having blocked nose with swelling. She was seen by a ENT surgeon, right? Biopsy done, revealed diagnosed scleroma. This story is like a 6 blind men and an elephant. So subsequently developed a hacking cough, seen by a physician, given a cough suppressant without finding out what actually happened. And she developed a ear discharge. Then once again she went back to the ENT surgeon, but then subsequently she had an abdominal pain with worsening cough and headache. So she was her up to have hypertension. And what did we have? If you look at her picture, what do you see? A depressed nasal breach, bilateral nasal, bilateral ear discharge. So, myriad manifestations in a single child, and she was being seen by a lot of our colleagues. So, how do we make sense of it, Dr. Anju?
So here we have an adolescent girl who has got a long-standing symptoms of various systems. So there is primarily involvement of upper airway, there is involvement of the lower airway, and gradually, because of not receiving any treatment, she progressed to the abdominal complaints with hypertension issue, suggesting of nephritis most probably. So they are multi-systemic involvement, and the chronicity led to the presence of the saddle nose deformity because of the chronic inflammation ongoing in the nasal bridge. So most probably the child is having, so this type of combination, a triad of upper airway involvement, lower airway involvement, and nephritis. Most common autoimmune disease that we see in these children is ANCA-associated vasculitis, most probably a Wegener's granulomatosis.
Thank you so much. Thank you. So, when we did this investigation, now, Dr. Anu, I've given you the investigation. Dr. Anju talked about the clinical manifestations. I want you to talk about the investigations which we have here.
Okay, sir. So here we have a child, like Dr. Anju said, lower respiratory tract, upper respiratory tract, and now looking at the combination of nephritis with respiratory ANCA-associated vasculitis. So hemoglobin is low because she's a 16-year-old girl. So 10 is low for her. Counts are okay, but there are neutrophilic predominance. Uh, Platelets are on the higher side, suggesting some form of inflammation. ESR is high. The creatinine is deranged, and X-rays showing multiple cavitatory lesions in the right middle zone, right lower zone, and also in the left upper zone here. And also retrocardiac area is also showing some form of cavitatory lesions. So I would like to get a CT in this child, CT chest. Yeah.
Thank you so much. So, Dr. Suma, when should a pediatrician suspect ANCA-associated vasculitis?
So there are a number of scenarios. ANCA vasculitis is always a multi-system disease. So it can be fever and constitutional symptoms along with persistent upper respiratory tract features like the blocked nose you described here. Inability to blow the nose is a specific symptom the patient uses. Persistent inflammatory, sinusitis, middle ear disease. You can get polychondritis. So involvement of the oral cartilage or the laryngeal cartilage. You can get lung disease, as you showed here, a combination of lung and renal. So the pulmonary renal syndrome, again, it comes in the differential diagnosis of
Absolutely.
And of course, skin lesions. Skin lesions can be purpuric looking like IgA vasculitis, but these patients have much more constitutional symptoms and very elevated inflammatory markers and perhaps ulceration of the lesions as well. So these are all usually the things that we see.
Thank you so much, Suma, for being so precise with what are the various manifestations of ANCA-associated vasculitis. Now, why is it important to diagnose and treat them early?
So this is a very aggressive disease. And if you don't, it's potentially fatal if not treated properly. Once they develop the severe organ involvement, they can actually die if it's not treated with the appropriate level of aggression. There are protocols, there are many rules to follow when we treat these conditions. They can also cause significant morbidity. I mean, the saddle nose is a cosmetic deformity, but if you have laryngeal cartilage involvement, that can be an extremely difficult sequelae to combat. So there are many issues with this disease. So it really needs specialist, attention and treatment right as early as possible.
Thank you so much, Suma. So coming to case 4, 13-year-old boy presented with fever of 1 week, headache of a week, intense photophobia of a week's duration. That's when he got admitted. When physical examination revealed a febrile child who had significant unilateral tender cervical adenopathy and had meningeal signs, and he had conjunctival congestion. So there was a history of Kikuchi-Fujimoto disease diagnosed a year earlier based on a lymph node biopsy. Now, during this admission, he was treated with antibiotics and antivirals for a week before he was referred. So the reason for referral was lack of response to antibiotics and antivirals. So, Dr. Anu, what are your thoughts about this case?
Anu?
Please unmute.
Sorry, sir. Sir, can you go back to the clinical slide? So this is a 10-year-old boy a 13-year-old boy who presented with fever, headache for a week, and intense photophobia. When we see this combination of symptoms, we think something is going on in the CNS. And the commonest thing is pyogenic meningitis in this age group. And I would also like to think of if the fever is of 1 week, it's a shorter history for TBM, but that would also be differential diagnosis down the line. But another thing, sir, here is a unilateral cervical lymphadenopathy. There are meningeal signs and conjunctival congestion. Here, I would like to say that first possibility with an acute history of fever, I would think of Kawasaki disease with a CNS involvement, or in fact, the Kikuchi disease that he had a year earlier, maybe an extension of that. So, both the things we would have to think, and the counts and the inflammatory markers in the CSF examination will give us the further clue as to how we should proceed.
Thank you so much. I would agree with your differential diagnosis, pyogenic meningitis, early tuberculous meningitis, or even a Kikuchi-associated meningitis. Now, when we did this investigation, this is what we found. Dr. Anju, can you interpret this for us, please?
So in the investigations, we are seeing that hemoglobin is low. Maybe so we need to see the peripheral smear with whether it is normocytic normochromic anemia or it is something else. But definitely the child has got anemia. TLC, WBC count is normal with the normal distribution of the neutrophils and lymphocyte. Again, platelet count is normal. ESR is very high. It is around 80, and there's mild elevation of liver enzymes. Mild to moderate elevation of liver enzymes. So like we were thinking that the child has duration of illness of 1 week. So we hardly think about rheumatic diseases in such a situation. But still, if we have to think with the background history of Kikuchi disease, where we can see a similar type of picture where there can be mild transaminitis, ESR may be elevated, counts may be normal. Sometimes we do see leukopenia in Kikuchi disease, but most of the time we can see normal counts as well. Apart from that, in the CSF, we are seeing a picture of aseptic meningitis-like picture. There is basically lymphocytic predominance in the CSF, but the culture of the CSF biofire is negative. So we are more sure that we have excluded all the infections. So we are left with other differentials which Dr. Anu has kept, like Kikuchi disease or Kawasaki disease. We know in Kawasaki disease, we see high inflammatory markers in the blood. We see leukocytosis, thrombocytosis, high ESR and CRP, which is not there. And so we are left with the last differential of Kikuchi disease with the background history of a similar type of illness 1 year back. So we can keep a possibility of Kikuchi disease on the basis of these investigations.
Absolutely. So, Suma, you have had a lot of experience
Yeah.
diagnosing and treating Kikuchi Fujimoto disease. What is a normal clinical presentation? Now, I presented a slightly abnormal, atypical presentation. Well, how do these children normally present?
So normally this becomes a differential diagnosis of like a subacute PUO with a unilateral lymphadenopathy. And the other classic features, the fever will be very high, spiking fevers. They will usually tend to have low counts. So total counts will be low. Hemoglobin platelets may be a little low as well. And it's often leukopenia with neutropenia that you see in Kikuchi disease. Sometimes Kikuchi can be the forerunner for lupus. Those patients will classically have lymphopenia. Kikuchi it's actually an abnormal immune response to usually an infectious trigger. And therefore, in this abnormal infectious response is in a spectrum. So if it is a very severely abnormal infectious response, you can even get a secondary HLH. You can get a presentation like what Anand showed us with an aseptic meningitis. And so what we do with these patients, to make a diagnosis of Kikuchi, you need a lymph node biopsy. Clinically, you can suspect it. You can only make the diagnosis on a lymph node biopsy that shows the characteristic necrotizing lymphadenitis that is seen in this patient. There are characteristic histiocytes described in the biopsy that help us to make this diagnosis. This is a self-limiting disease in the vast majority of patients. For some patients, interestingly, just doing the lymph node biopsy itself can self-limit, can actually put a stop to the fever and the counts start improving. For the majority of patients, NSAIDs like naproxen, a long course over 4 to 6 weeks is adequate to control the disease. Some patients, if they may not be adequately responsive to naproxen, or they could have complicated disease like the aseptic meningitis. Sometimes you can get cranial nerve palsies. Sometimes you can get secondary HLH or hepatitis, etc. These patients will need steroids. Where the prognosis is usually excellent, and a few patients could actually have recurrent Kikuchi, so about less than 5%. And for these patients, sometimes using secondary immunosuppressant, hydroxychloroquine, mycophenolate, azathioprine, can keep the disease in control.
Thank you so much, Suma. So we did publish this case with aseptic meningitis in Indian Journal of Rheumatology. Now, coming to case 5, more straightforward. 12-year-old boy came with complaints of painful swelling of joints of the lower limbs, lower back ache, and as you can see, he had uh, decreased anterior posterior spinal mobility with modified Schobers of only 3 centimeters. He had bilateral sacroiliac joint tenderness with restriction, and he had 7 enthesitis points. Dr. Anu, what would you suspect? How would you investigate this patient?
Yeah, I'm sure the audience has by now realized that most of our rheumatological illnesses have a pattern. There is a paradigm that you need to recognize. And if you learn to recognize those patterns, it becomes easy. Now, this is a, sir, please, can you go back to the slide? Yeah, so it's an adolescent boy who is coming with a predominantly lower limb arthritis, right? And a back pain. So my diagnosis is not going to be anything else except for enthesitis related arthritis. This is a classical presentation, and most of these children are missed. They keep taking NSAIDs outside from the local practitioners and RMPs, and then these children come very late. At least in North, they do. They come pretty late. So this is a no-brainer. So this is an enthesitis-related arthritis. I would go
Okay.
ahead and do HLA-B27 and an MRI SI joint.
Okay. So,
know anything else.
Anju, how would you interpret the labs for us?
Oh, I
Uh,
forgot.
so enthesitis-related arthritis is one of the most common subtype of juvenile idiopathic arthritis seen in Indian population, if we talk about, as compared to oligoarticular JI, which is seen most commonly in the Western population. So we need to talk about this disease a little bit in detail. So it has got a phenotype where there can be some significant elevation of acute phase reactants. So as we can see in the blood, that WBC count is elevated and there is neutrophilic response, there's thrombocytosis, high ESR, and if we get in CRP, then that would also be elevated. And there is anemia, which might be most will be normocytic, normochromic in nature as an anemia of chronic disease. And as Dr. Anu suggested, since we are thinking of enthesitis-related arthritis, we have to investigate with HLA-B27, which is positive in around 75 to 80% of the children affected with this disease. And since the child has clinical manifestation of sacroiliitis, so the imaging of choice is MRI of the pelvis, and that is oblique coronal view of the sacroiliac joint. That is a desired imaging that we get done in these children, and which shows, like in this child, he had inflammatory low back for the duration of 6 months, which was evident in the MRI pelvis in the form of bilateral sacroiliitis. So this child has got sacroiliitis, which is axial disease. He had enthesitis and blood showing high inflammatory markers.
Thank you so much, Anju.
Dr. Anandrao, can we just a little bit hesitant?
I think we'll stop after this case if it's
Anand,
scheduled
I
later.
think keep the last case after
Okay.
this.
If you can just briefly answer this, then we'll go to the last case and finish it off.
You can give key messages, yeah,
Okay.
about the
So,
cases.
okay. Adult equivalent of the disease, very brief.
Ankylosing spondylitis.
Are they different?
The only difference is that in children, the enthesitis related arthritis predominates initially. Those with HLA-B27 are at positivity are at a higher risk to go to axial disease, but even HLA-B27 negative children can go on to axial disease. So that the blood test is a prognostic marker for this presentation. And the consequences of delayed recognition and improper treatment are that these children develop significant deformity over time and with the bamboo spine. And this is the stage when they first develop a sacroiliitis, we need to use the right disease modifying agents to prevent the sequelae from happening.
Absolutely. Thank you, Suma. So, going to the last case because we wouldn't have time.
But this is, I think, the last case is something that all pediatricians will see.
Okay. A 13-year-old girl who was brought with complaints of swelling of the right forearm along with the right hand for the last 9 days. And she's had some skin rashes on the affected limb. There is a history of drum practice on a daily basis for the school sports event for the past 1 month on a daily basis. And the parents reported that she's a very sensitive girl and who is very introvertish. And this keeps her from speaking too much even in the family. And as you can see that she had dorsal fullness, she had swelling of the right upper limb as compared to the lower limb. And you can also there see that she had mild erythematous brownish rashes which were there over the forearm.
Can I also ask if the hand was cold compared to the other hand?
Yes, the hand was cool to touch. There was hyperesthesia, there was allodynia, and there are erythematous patches. The rest of the systemic examination was normal. And you can see that the investigations were all bang normal. So, Anju, thoughts? Is it common in your practice? And finally, Suma to conclude.
So this child is having swelling of one limb, unilateral swelling of a limb, along with some features of autonomic changes in the form of allodynia, hyperesthesia is there, coolness of extremities there. And it is an acute episode preceded by some heavy exertion in the form of drum practice with the girl did. And so this is an example of non-inflammatory type of manifestation that we see called complex regional pain syndrome, which was previously known as reflex sympathetic dystrophy. So it is a type of pain amplification syndrome where the blood parameters are normal. In fact, we do not investigate at all in this child if we are sure on the basis of detailed history and examination, because in most of the time we will find everything is normal. So this child most probably had this non-inflammatory aches that we called complex regional pain amplification syndrome. It is not that common, but it is not very rare also. Maybe we can see 1 to 2 cases per month.
Thank you so much, Anju. Wonderful. Suma, you have
So,
seen complex regional pain syndrome, you have seen generalized pain amplification syndrome.
yes, yes.
How are they different?
So
And how do you
basically,
treat these patients?
yeah, this is a little more complicated than generalized pain amplification syndrome because there is the sympathetic component that has entered this patient. The pain amplification syndromes are extremely common in my practice. I tend to see one a day, and I'm not exaggerating. Now, the thing here is with this particular patient, the treatment would actually involve mobilization, so graded active mobilization along with cognitive behavioral therapy. This is what is going to help the patient, not rest, not putting a cast, not actually not using that, encouraging not using that hand anymore. That will actually set her back, and it will become even more difficult to rehabilitate her with time. Pain amplification syndromes are extremely common, actually, and often the history, the high level of symptomatology, very significant lack of signs or any contributory elements on routine investigation should make us suspect that there is no real organic medical disease here. We need to stop medicalizing the patients and get them into rehabilitated treatment as soon as possible.
Yep. So she would require physiotherapy,
yes,
and psychotherapy in the form of cognitive behavioral therapy.
Yes.
And we tend to avoid medications.
Medications don't really help. There's a very small subset who will respond to medications.
Thank you so much. I have had wonderful panelists, and thank you for bringing out the best of pediatric rheumatology in adolescents. Thank you so much. I'll stop sharing.
Thank you, Dr. Anand Rao ji. Very, very interesting. And, cases at the end of the, though it is quite late in the night, 60 to 70 people are still hearing to you. And this recording will be available to all the pediatricians, and will be mailing the recording to all the pediatricians who are not able to attend. So this will be on records with us. Thank you so much, Dr. Anand, especially for nicely moderating this session. Dr. Suma Balan, who's from Cochin, she's from Amrita Institute. I met all of these people here who have been on the panel. They have been having, they bring a lot of expertise, huge experience with them. Thank you, Dr. Suma, for being with us. Dr. Anju Singh from Delhi, and also Anu Maheshwari from Lady Hardinge Medical College. Thank you so much for your insights into this rheumatology, which is very, very common among adolescents. Many of the cases present to the pediatricians, and you have really empowered us. Thank you. Now over to Gurdeep Singh, who's a young Haemato-Oncologist from Ludhiana. He's from Dayanand Medical College, Assistant Professor of in Rheumatology. Dr. Gurpreet, I request you to kindly bring in the youth voice, the youth perceptions, and dealing with Haemato-Oncological issues. How do they feel about all these issues? How, because we always want to hear from the young people. Over to you, Dr. Gurdeep.
So, good evening, ma'am. And thank you for all the organizers for inviting me for this session. I'm Dr. Gurpreet Singh. I'm working as a pediatric hemato-oncologist in DMCH Ludhiana. So, for the last 5 years since I have been practicing pediatric hemato-oncology, I have come across a lot of adolescent cases. And one thing which I have learned from this, that treating an adolescent is not same as treating a younger child. They are different people, they have their feelings, they have their fears, and the most importantly, the most difficult thing is that they ask questions. So whenever an adolescent comes to us, when we go for their diagnosis, the first the question we have to answer is, what are they suffering from? So what do you think? Should we tell them that yes, they're having cancer, or should we not? So I would like the people who are the participants to answer, what do they think in this regard?
Yeah, Dr. Sirisha Rani, are you still here with us? Dr. Sirisha?
Yes, ma'am. Yeah.
We deal with a lot of children and families and adolescents. So should we really reveal that the child is having cancer? Can we tell the adolescent?
So most of the times, whenever we counsel them, parents always, as we know, like in India, still in the adolescent age group, first contact will be parents. So first, when we counsel the parents, they always say hide from the child the fact that they have cancer. So we do hide it to begin with, but later on we have to go ahead and sit one on one and then explain to them that what they are going through is this, and then how they can get better, what are the long term implications. Otherwise, slowly the hair falling, all those things are going to cause more agony for them. So we have to reveal it to them, but it has to be in phases rather than in one go.
Yes, ma'am. Actually, that's the best way to go. Actually, just sitting, we have to sit together with them. First, we have to win their trust. Then we have to, step by step, we have to ensure them that yes, this is what you're suffering, and yes, their disease is curable. Because if an adolescent, like you peep them in a cancer ward, they are smart enough to run through their mobiles and find out what they are suffering. And at that time, when you lose their trust, things are going to go bad for us in the long run. So that is very important. I have
And they always require help from psychologists. So
yes,
I'm sure you would have come across.
Yes. So I happened to record a video of an adolescent. Like a few questions I asked him, like what is like he has a case of anaplastic large cell lymphoma. It's been 3 months, like he has been going through the treatment, and like I asked him the routine questions of what he has gone through. If the participant order, I can like to share it into this meeting.
Please share, Dr. Good.
Yeah.
Is it visible?
Yes, yes. Please go ahead.
So it's in Punjabi. I hope you'll be able to get some part of it.
ਅਗਲੇ ਹਸਪਤਾਲ ਗਏ ਉਹ ਵੀ ਠੀਕ ਕਰ ਪਾਏ ਹੌਲੀ ਹੌਲੀ ਫਿਰ ਵਿਸ਼ਵਾਸ ਹੈ ਉੱਠਣਾ ਹਟ ਗਿਆ ਵੀ ਕੋਈ ਠੀਕ ਵੀ ਕਰ ਪਾਓ ਫਿਰ DMCC ਜਦੋਂ ਆਏ ਉਦੋਂ ਸਾਰਾ ਕੁਝ ਠੀਕ ਹੋ ਗਿਆ
ਜਦੋਂ ਮੈਂ ਬਿਮਾਰੀ ਬਾਰੇ ਦੱਸਿਆ ਸੀਗਾ ਐਸੀ ਕਿਹੜੀ ਚੀਜ਼ ਸੀਗੀ ਜਿਹੜੀ ਤੈਨੂੰ ਸਭ ਤੋਂ ਜ਼ਿਆਦਾ ਮਤਲਬ ਕਨਫਿਊਜ਼ਨ ਦਿੰਦੀ ਸੀ ਸਮਝ ਨਹੀਂ ਆ ਰਿਹਾ ਸੀ ਉਸ ਦੇ ਬਾਰੇ ਉਹ ਕੀ ਸੀਗੀ
ਇੱਥੇ ਢਿੱਡ 'ਚ ਗੰਦਾ ਪਾਣੀ ਸੀਗਾ ਜਿਹੜਾ ਉਹ ਸਮਝ ਨਹੀਂ ਆ ਰਿਹਾ ਸੀ ਕੋਈ ਗੰਦਾ ਪਾਣੀ ਸੀ ਜਾਂ ਬਲਗਮ ਸੀ ਜਾਂ ਕੀ ਸੀ
ਠੀਕ ਹੈ ਤੈਨੂੰ ਕਿਸੇ ਨੇ ਤੇਰੀ ਬਿਮਾਰੀ ਬਾਰੇ ਕੋਈ ਮਤਲਬ ਸੌਖੇ ਢੰਗ ਨਾਲ ਸਮਝਾਉਣ ਦੀ ਕੋਸ਼ਿਸ਼ ਕੀਤੀ ਤੇ ਕਿਵੇਂ ਸਮਝਾਇਆ ਸੀਗਾ
ਮੈਨੂੰ ਇੰਨਾ ਕੁ ਦੱਸਿਆ ਗਿਆ ਬਸ ਵੀ ਇਹ ਇੱਕ ਬਹੁਤ ਗੰਦਾ ਪਾਣੀ ਹੈ ਜਿਹਨੂੰ ਹਨਾ 2 ਸੂਈਆਂ ਨਾਲ ਬਾਹਰ ਕੱਢਤਾ
ठीक है
बहुत ही आसानी नाल
अपने इलाज दा सब तो एक औखा पार्ट दस सब तो औखा पार्ट जेड़ा तैनू लगता है
सुई लो
केड़ी सुई इतना तेल लगी हुई है
Can you translate that for us, Dr. Gurdeep?
So basically, we asked him like what was the hardest part of experience during his entire treatment till now. So initially, what he told was that the frequent cannulations he had to go in the initial time, and in the later phase we got for the PICC line, so that thing was eventually stopped. So the pain, the adolescent, they take up this pain in a very difficult fashion. That is the sickest part of therapy which he experienced during the entire course till now.
Really appreciate you that you had captured the feelings and the voice of the adolescents.
किस तरह करते हैं
भी ਇਹ ਤਾਂ ਬਸ ਛੋਟੀ ਸੂਈ ਹੈ ਇਹ ਤੈਨੂੰ ਕੀ ਕਰ ਦੂਗੀ ਇਹ ਤਾਂ ਵੱਡੇ ਵੱਡੇ ਲਾ ਲੈਂਦੇ ਤੂੰ ਹਰੇ ਇੰਨਾ ਛੋਟਾ ਇੱਕ ਵਾਰ ਲਵਾ ਕੇ ਦੇਖ ਨਹੀਂ ਜਮਾ ਨਹੀਂ ਪੀੜ ਲੱਗਣੀ.
So his father has been quite supportive during his entire treatment. So when when the children, the adolescents especially, they have the support of the family along with the doctor, so that's really helped them to cope up with the stress they are going through. The family has been very supportive. They have been motivating him all along that whatever he has been going through, all the complications he's having, they are just temporary, and he's going to pass through them in a very well. And that he's going to be cured in the ultimate long run. So that's what's been keeping him strong and running till now.
Okay.
फैमिली किਵੇਂ सपोर्ट करती है ਮਦਰ ਕਿਵੇਂ ਸਪੋਰਟ ਕਰਦੇ ਆ, ਪਾਪਾ ਕਿਵੇਂ ਸਪੋਰਟ ਕਰਦੇ ਆ, ਕੌਣ ਜ਼ਿਆਦਾ ਕਰਦਾ ਹੈ?
ਵੀ ਪਾਪਾ ਕਹਿੰਦੇ ਹੁੰਦੇ ਵੀ ਡਰੋ ਨਾ, ਹਨਾ, ਜਿਹੜੀ ਵੀ ਚੀਜ਼ ਲੱਗੀ ਬਸ ਇੱਕ
He knows
ਗੱਲ
the
ਹੁੰਦੀ ਹੈ,
diagnosis,
ਬਸ
right?
Yes,
ਜ਼ਿੰਦਗੀ 'ਚ ਇੱਕ ਔਖੀ ਚੀਜ਼ ਹੁੰਦੀ ਹੈ,
some part
ਬਸ
of it.
ਜਿੰਨੀ ਆਪਾਂ
Like
ਔਖੀ
we
ਚੀਜ਼
have told him
ਸੋਚਾਂਗੇ
only some part of it,
ਉਨੀ
not
ਅੱਗੇ ਜਾ
exactly.
ਕੇ
We haven't
ਸੌਖੀ
used the word
ਹੁੰਦੀ।
cancer form
ਕਿਹੜੀ
because the
ਕਲਾਸ
family was really against it till now.
5th ਕਲਾਸ ਵਿੱਚ ਕਿਹੋ ਜਿਹੇ ਸੀਗਾ ਪੜ੍ਹਾਈ 'ਚ ਪਹਿਲਾਂ? ਸੱਚ ਬੋਲਦਾ ਹੈ।
ਪਹਿਲਾਂ
He discusses about the
ਨਰਸਰੀ ਤੋਂ
diagnosis
ਤਾਂ
or
ਯਾਦ ਆ,
prognosis,
ਫਸਟ
sorry,
ਕਲਾਸ 'ਚ
prognosis.
ਆਇਆ,
Prognosis,
ਫਿਰ
sometimes he asks us
ਵਧੀਆ
how much
ਨੰਬਰ
time is going to
ਆਏ,
take,
90 ਤੋਂ
what's
ਉੱਤੇ
going to be my
ਮੈਡਮ
life
ਮਿਲਦਾ,
after that.
ਸੈਕਿੰਡ ਕਲਾਸ 'ਚ ਆਇਆ,
The one
ਗੋਲਡ ਮੈਡਲ
question that he
ਮਿਲਦਾ,
has repeatedly asked me
ਥਰਡ ਕਲਾਸ 'ਚ
about his hair
ਥਰਡ
actually,
ਮੈਡਲ
that
ਮਿਲਦਾ, ਫੋਰਥ
when we
ਕਲਾਸ
like
'ਚ
when he
ਥੋੜੇ
had
ਨੰਬਰ
started
ਘੱਟ
having a lot
ਗਏ,
of hair fall, we
82
advised
ਖਾਨੀ
him to go for a
89 ਰਹਿ
complete
ਗਏ,
head shave.
ਤੇ ਫਿਰ
So initially he was
ਫਿਫਥ ਕਲਾਸ
anxious,
'ਚ
but now he has totally coped up with it.
ਟੌਪਰ ਸੀਗਾ
So
ਆਪਣੇ
the one
ਕਲਾਸ ਦਾ।
part is which worries the adolescent a lot is the body image would go with, like with
Body
changes
image,
with the
yeah.
treatment. Like the steroids, they are going to lead to a lot of like weight gain and chubby faces. The hair starts falling eventually. Then the leg pains which they go through. So it's a body. Like I have one adolescent girl. She's 11 years. So when she had a first hair fall, she has just kept that hair and she's kept it in some nice collage or diary. She has saved that hair. So initially I was worried. So we went for a psychological counseling. Now everything is normal with her and she's able to cope up with everything.
It's really
So
great.
these children, they require a lot of specialized care apart from the chemotherapy when we give them.
Absolutely.
It's not only that, like we have to address their day-to-day problems. They have a lot of questions, and without the help of a good psychologist and the nursing staff which understand them, treating them is a big task.
Yeah, thank you.
Then,
So
yes, ma'am, please continue.
yeah, no, I just want to say that you can just tell on behalf of the young people. So we have been personally, all of you have been treating, including Dr. Sirisha, and all these long-term problems, especially Haemato-Oncological and rheumatological issues. What are the specific problems relating to the adolescents regarding the compliance with treatment, long-term prognosis? What do they visualize themselves about death and etc.? So, like how you would like to, your key messages in managing this apart from medical treatment to the pediatricians?
So basically, when we start treatment of the patient, we ensure them that yes, this disease is curable. You're going to be completely all right, and yes, you'll be able to lead the life of a normal child. We just ask. I mean, majority of the cancers, the first 6 months, they are the difficult part, and after that, yes, the things do become easy for them. Of course, they will be going through a lot of changes. Their body will like show a lot of changes. Like gain in weight will be there, hair loss will be there. They will feel a little weak, a little lethargic as compared to other patients. Apart from that, there will be some restrictions, but eventually, it is for his own good. Slowly and slowly, when we go through them, the children start to understand this. They become our friends. For them coming to hospital, it becomes like a more of a play. Like yes, we're going there for a day. We're going to meet our friends there and then spend some time with them and then come back home. This is the kind of atmosphere at least I like to create for my patients when I treat them, especially the adolescent ones. Then apart from that, the psychology team at our institute, like they're doing a wonderful job. Like they come on a regular to regular counseling basis, which is required in the initial phases of the treatment. And then eventually things start becoming better for them also.
Okay. Dr. Sirisha, any messages you would like to leave
So
for the
yeah, I
pediatricians?
do agree with Dr. Gurpreet that first we need to give them reassurance that it is curable, and then we have to take them forward in the treatment with a positive note. And of course, as you said, compliance is a big issue, not only with malignancy, also with hematological diseases, chronic hematological diseases, especially sickles. They stop using hydroxyurea, they come with recurrent pain crisis, they can go into other major crises. So we have to tell them the importance of taking the medications. They always question you, why me? So why do I have to go ahead and take the medications lifelong? Why I have to go through this problem? So that why me question is a big thing. So we always tell them that they are more strong. That is why they are getting tested in that way. But it is easy to say how much they are going to observe from that. We do not know, but still some of them they do bounce back and then they get into good compliance. But we do face compliance issues in adolescents. That is one thing. And of course, body image is a big thing. We have to ensure on that they get adequate psychological support, especially in the beginning. But as the time passes, when they are going through the treatment, they do understand that they become pain free. Initially, cannulations, later on, line will be there, so they become pain free. And at the same time, as Dr. Gurpreet mentioned, yes, they do come as a daycare. So that is one thing we have to ensure. And the other thing is like schooling, school, college, and all they do miss. So we have to go ahead and tell the parents to arrange some online classes for them so that they don't miss. They don't feel some of our kids, they have written 10th classes, +1, +2, they scored very well, almost 85, 90%. So while undergoing through the intense phase of the chemotherapy, so we were very surprised. We took special permission for them to write the exams by keeping them separately rather than mixing with the other kids. So all that we have to ensure that not only chemotherapy, also other aspects of the treatment we have to address.
Thank you, Dr. Sirisha. Gurpreet ji, anything, any inputs from your side? Anything else you would like to add? Or
I think Dr. Serisha has covered most of it and she's given the right crux of it which is required.
okay, thank you. So basically, I really appreciate all the Anand Rao and all the panelists are here. So while dealing with adolescents, this, especially we have taken up, thank you, Dr. Anandrao. You had any key message for handling adolescents, not just from the medical point of view, just like the psychological and other aspects, how difficult or how easy is it? Do you want to reveal the diagnosis to them? And, we usually feel we body image issues, the school dropouts, chronic disease, compliance issues, all these are challenges for a pediatrician. So what is your one line, some few key messages regarding this?
No, with adolescents, I think it's very important to have a shared decision making with them too, because they're not completely adults, but it's very important to get them on board, because what happens with these adolescents is the compliance issues tend to become more manifest because they are neither children nor adults. They unlike children, they can't be guided to take their medicines, and unlike adults, we can't expect them to be aware of their disease, and compliance issues tend to be a major problem with the adolescents. And the other problem is the body image, as you rightly mentioned, is also a major problem, because of which they don't take medications like steroids because or hydroxychloroquine, because steroids makes them look plump or obese, and hydroxychloroquine gives them a slate gray complexion, which they hate, which is a typical Indian mindset. So these are issues which we commonly encounter: compliance issues or oppositional defiance, and they some of them don't want to visit us because we are going to write some medicines which will make them look abnormal, and they're made fun of with their by their classmates. So a lot of psychological issues, lot of issues which are associated with transition from a child to an adult crop up during this age, and it makes treating these patients a little bit more difficult as compared to, say, a less than 12-year-old.
Thank you, Dr. Anandrao. There's so much to discuss more about all this, but it is quite late now. And thank you, Dr. Sirisha Rani, Dr. Anandrao, and all the panelists for really empowering our pediatric body, especially IAP AHA. We are dealing with adolescents, and this super specialty topic is very important for us because we do see a lot of rheumatological issues in adolescents, and especially the even hematological issues and how to deal with them. You have really given us a lot of insight into all this. Thank you so much. Now I request if there are no questions on the chat box, I request Dr. Sneha Gadkar, a treasurer of AHA, to formally put the vote of thanks. Thank you.
Thank you, Dr. Haemato Madam. Being concluding super specialty webinar of this Silver Jubilee year, we are today blessed with our CIAP office bearers. So I thank to Dr. Kharatkar, President CIAP, past President Dr. Basavaraj, and Chairperson-elect Dr. Singaravelu for guest of honor. I also thank Dr. MKC Nair, who was all the time guiding us throughout the year, and because of his direction and his vision, we could do so many new things this year. So I really thank Dr. MKC Nair sir. And there was an excellent session today. Both the topics, they are really, we always feel that they are really dry, but our speaker and panelists made them very interesting. So Dr. Sirisha Rani, it was a very good presentation about the hematological issues, and there is no words to say. Thanks to Dr. Anand Rao, he made panel discussion so interesting, and all panelists were excellent. I thank Dr. Suma Balan, Dr. Anju Singh, and Dr. Anu Maheshwari for giving their excellent opinion. And yes, Dr. Gurpreet Singh, as a Yuva voice, he has shown us the different phase of what adolescent think once they get the diagnosis about the disease, and it's a real major issue which should be taken into concern. So I thank Dr. Gurpreet Singh for giving us and enlightening us a different aspect of the disease to tackle with. I thank Dr. Hemabindu Madam. She is so energetic, enthusiastic, and ever like we should say powerhouse battery. She worked day and night throughout the year and really kept all of us in a better way, and we could upgrade ourselves in knowledge as well as in the programs. Thank you very much. Thank you all.
I thank all of you. Dr. Jesse Gar sir abhi bhi hai. Thank you so much, sir. Dr. Of course, all our experts today. Dr. R.N. Sharma sir, thank you always for being with us. हमेशा you have been our back support. I mean, हम बेफिक्र रहते हैं जब आप सभी रहते हैं. And Dr. Sneha, of course, my good Saheli, I should say. Dr. Arya sir in his absenteeism today. Dr. Shamik Ghosh, all the office bearers, Dr. Geeta Patil, Dr. Sushma Desai, and all my very dear executive board members, 2 from each zone. Each one of them, I really thank them. And this is the last super specialty webinar. So thank you, Dr. Sirisha ji, to make it very special for us, Dr. Anand Rao, all the panelists. So this is something we look forward every Thursday because we bring in some topic where our general pediatricians don't go into that, depth. And we really we learned a lot through all the super specialty webinars from all of you. Thank you so much. I thank all the pediatricians who have attended today, all our IAP members and AHA members. Thank you one and all. Thank you. Thank you so much.
Thank you, ma'am.
Yeah.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.